All right, so this is round 2 of answering questions from DFSP patients from the Facebook support group. So we have one right now. What's your question?
Yeah, my question is, does DFSP on scans appear in a unique way so that you can straight away say that's DFSP, or can it be confused on scans with things like lipomas and cysts?
So can DFSP, does it look unique on a scan or does it look similar to other things? I'm not a radiologist, so I'm not totally certain, but I think it could look like a lot of other types of tumors. It would probably look different depending on the kind of scan you have. It would probably look different than a cyst because cysts are empty in the middle or they have loose material, not like solid tissue. And lipomas are fatty, so if you do an MRI, say, MRIs can tell fat from fibrous tissue and other stuff usually. So they could tell those things apart, but DFSP could look quite similar probably to other types of tumors and other things on a scan. So it doesn't have a totally unique signature that I'm aware of. There may be some cases where they might suspect that based on the way it's growing and where it is in the skin, but the only way to know for sure that somebody's DFSP is to do a biopsy and examine it microscopically.
Two questions. How does DFSP-FS transformation develop? Is it another mutation from regular DFSP, or is it just a different variant altogether? And are clear margins as good as any, let's say narrow margins versus 1 centimetre margins or greater?
Okay.
Thank you, and so grateful you're available to help us.
Oh, well, I'm happy to help. How does fibrosarcomatous DFSP develop? So fibrosarcomatous DFSP, or fs-dfsp as we abbreviate it, is a higher grade, more rapidly growing form of dermatofibrosarcoma protuberans. It's probably not a separate variant, it's probably kind of what we call higher grade transformation. The tumor suddenly starts growing more quickly, the cells divide more rapidly, and we see that microscopically because the fibrosarcomatous DFSP are more cellular, the cells are packed closely together, and they tend to have more mitoses, which is how cells divide. So those are both evidence that the tumor's growing, the cells are dividing more quickly and growing more quickly. As far as why or how it happens, I don't know, and I don't know if we have a good answer to why. The fibrosarcomatous area still has that same translocation. It may be that it picks up new mutations that allow it to grow more quickly, but I'm not exactly sure to all the answers. I think there may be some data about that, but I'm not totally familiar with it yet, and I think that we don't have the exact answer for why it occurs. And then the next question was margin status. Is any negative margin good enough, or is there a difference between narrow margins and wide, 1 to 2 centimeter margins or greater? I think the answer is always that the wider the margin is, the better. Because anytime you have a narrow margin, a really thin margin of say 1 millimeter or 2 millimeters, that might look negative on the areas that we're looking at under the microscope, but there's always a risk that we're not seeing the whole thing. So when we do a wide local excision, we slice up the specimen like a loaf of bread, and we look at each of those slices, but there's always area in between the slices that we can't see microscopically. So you could get around this by putting the entire margin in flat. It's kind of complicated, what we call en face, or how Mohs surgery kind of does it. They lay everything down and look at the whole margin. The problem there is you don't know how far you actually are away from the tumor. You're just seeing the margin, but you don't see how far you are from the tumor. So it's a little bit of a problem. One way looks at the whole margin, but doesn't tell you how far you are from the tumor. The other way tells you how far you are from the tumor, but doesn't give you, it's just giving you a sample of the margin. So there's no exactly perfect way to look at margins, but the risk is always that the closer a margin is, there's a possibility that there's a little area that was left behind, and that tumor could then recur. So a wider margin is always better, but if you've got negative margins, and I think that's a good thing, and if you're a patient, don't lose too much sleep over that. Just continue with your follow-up. Keep seeing your doctor, and if you have any new developments of lumps or bumps at that site, go back and see your doctor right away. But a negative margin of any sort is good, but a wider margin is probably generally better than a narrow one.
Hi Jared, I was wondering, does DFSP make you any more susceptible to other types of cancers? It may seem kind of like a dumb question, but it's had me kind of worried and making me wonder if I'll have to do extra checks or be even more careful with things like sun exposure than normal. Also, if you had DFSP, will any scar you get in the future be susceptible to develop DFSP, or is it just something we're born with that develops only in one place?
Okay, good question. So the first question is, if you have DFSP, does it make you more susceptible to developing other forms of cancer? And as far as I know, no, it does not. If there is any other risk, I'm not aware of it, and I've not seen anything in the literature that suggests it. The reason, we don't know why exactly DFSP happens, but what we think is that randomly inside one cell, two genes break apart. They split in half, and then they pair up with each other. So they kind of inappropriately pair. A pairs with B, basically. And what happens is that new gene gives rise to the cancer. So that one cell where that happens, that's kind of the mother cell of the whole tumor. The first cell, and then it divides, and all of the new cells of the tumor come from that one cell. So the rest of the cells in your body do not have the translocation. They do not have the DNA problem, just the cells in the tumor itself. So there should be no other risk of you that I know of. It wouldn't logically make sense to me why you would have any other significant risk more than anyone else of having other types of cancer. And also, the other question was, will you, if you get other scars in your body, will you develop DFSP in those? I don't see why that would happen either. I don't think that there's any risk, or I've never seen or heard of that either. So I don't think that there's any other risk. It's just where the tumor develops, that's the main problem. And that happens probably because of a random event, that just random bad luck that causes the genes to break apart, fuse together, and then grow into a tumor just at that area.
In the future, I really want to have kids, but do I have to worry about passing this on to them?
So that's a great question, and someone asked me that once before. Do I have to worry about passing on the risk of DFSP to my children? Are my kids more likely to get it because I had it? As far as I know, no, there's no risk at all, any more than the general population, of your kid getting DFSP just because you had it. And again, that goes back to what we were just saying, that the DNA problem that happens is not, like some people have syndromes where they have a problem in the DNA in all of their cells that make them more at risk to get cancer. That's not the case with DFSP. In DFSP, that molecular DNA problem happens just in that one cell and just in the tumor cells that grow out of it. So there shouldn't be any risk that you pass on to your kids that I know of, and I've never seen a mother or father that had a child with DFSP that they both had DFSP. So I've never personally seen that situation happen. So logically, I don't see why that would happen. I've not seen anything in the literature that suggests that your kids have a higher risk of getting it, and I've not seen any cases personally of that happening. So I think that that's something that you should feel pretty good about not losing sleep over.
Okay. I may be written off as a crackpot, but I wanted to know if there are any other instances of DFSP diagnosis that were made within 6 to 12 months of receiving a vaccination, especially hepatitis B. I know there is vaccine-associated sarcoma recognized in cats, dogs, and ferrets. I developed DFSP exactly at the site where I received my first ever flu vaccine and Hep B vaccine on the same day. I'd had a benign cyst at that site for 20 years. Then after the vaccination, which hit the cyst, 6 months later it grew into a palpable tumour and I was diagnosed with DFSP. I've always thought there was some sort of correlation.
Okay, so a couple of questions there. The story that was shared was that the person had a cyst at the site, probably on their arm. It was there for 20 years. They got an injection of a vaccine for flu and Hep B. And then soon after that area began growing quickly, and then they got a biopsy, and it was shown to be DFSP. With that whole story, without seeing it, it's impossible to know. But the story sounds suspicious that maybe it had been DFSP and not a cyst all along, because as we all know, DFSP often looks like a cyst when it first grows. Many of the people in the group have been misdiagnosed for years as having a cyst, and only after biopsy was it shown to be DFSP. So maybe it's just that was DFSP all along, and the vaccine was just a red herring. I'm not familiar with vaccines causing sarcomas in humans. It is true that in animals, some animals like cats, do get a certain type of sarcoma that develops after injection, at the injection site from vaccines. I've not seen that or heard of that happening in humans. And the type of sarcoma they get tends to be a higher grade sarcoma that doesn't look really or act like DFSP. It's kind of different than DFSP. So I think that's unlikely. I'm not familiar with anything to suggest that vaccines cause DFSP or any other type of sarcoma, to my knowledge, in humans. And I think that's it's hard to know without seeing that exact situation. But I think the shoulder area where you get vaccines is an area that commonly is where you see DFSP. I've seen many DFSPs of the upper arm. So it very well may just be a coincidence.
Could the relative trauma of the needle going into that area trigger it to, if it was DFSP, cause it to start growing, but it wouldn't be the vaccine?
That's a great question. So could the trauma of the needle cause the growth in the tumor? It's possible, and there have been other people in the group who have shared with me that after having trauma to a site where they may have had DFSP already, the DFSP started growing more quickly. And it certainly makes sense that when you any sort of trauma, needle, injury, or cutting, can cause growth factors to be secreted that are part of the normal healing response, and potentially those could lead to the tumor growing more quickly. I'm not sure that we have proof that that happens, but it does make logical sense that it could happen, and I've certainly heard stories to suggest that it does in some cases happen. The other thing that sometimes after you have a needle or an injection, you can get bleeding or hemorrhage, and that can show up as growth or rapid swelling. So sometimes when I hear a history of something that rapidly swelled or grew quickly, sometimes that's what's happened if there's been trauma that's caused bleeding underneath. The bleeding causes swelling and pressure, and that presents what looks like to the patient as growth, or even to the doctor. Sometimes it mimics growth, and people will get a biopsy done because something has started to bleed into itself and suddenly grown bigger. So we see that with other types of tumors, not DFSP so much, but other types of tumors I've seen that once they bleed into themselves, the patient comes in right away and said, this thing grew overnight, I really want to get a biopsy. And then what we see microscopically is that there's some blood there, and that's probably what's caused the growth, is actually just bleeding and swelling. That's a great question, good idea.
This one's a little technical for me. With immunotherapy being all the rage these days, I'm disappointed that there's been little success with sarcomas. There was a study of DFSP-FS treated with imatinib, which showed a tight association with T-cell infiltration in the post-IM specimens, suggesting an ongoing anti-tumor response. They identified the IM-treated fs-dfsp as potentially sensitive to immunotherapy. Your thoughts?
So, immunomodulation is when we give types of drugs that modulate and change the immune system and ideally make it attack the cancer cells. We use this for other types of things. Melanoma is one of the new things that we've been using. We use immunomodulating drugs for melanomas, other types of cancers, but not so much for DFSP. One drug that has been used for DFSP is imatinib, which is what it does is it blocks a molecule called a tyrosine kinase. It's a little technical, but it blocks a molecule that drives the growth of the tumor. And for some patients, it works really well to slow down or kind of make the tumor even shrink down. For most people, it's still up in the air whether it can totally cure DFSP. What I've always been told from oncologists that I know is that it can slow down DFSP or even make it stop growing, but probably doesn't totally cure it or make it go away. And the study they're referencing is that in some fibrosarcomatous DFSPs that they used imatinib and had some success with that, and that there were, what they said, T cells that infiltrate into the tumor. And what do I think about all that? I think that it's a promising area to look into, and certainly it is all the rage. It's something that's growing in other types of cancer. We've not seen a lot of success yet in sarcoma, but I think in the past 5 years, we've seen a lot of success in other types of tumors with not just immunomodulating therapy, but targeted therapies, drugs that specifically target certain molecular pathways inside the cell that can hopefully knock down tumor cells and not harm other cells in the body, and or can modulate the immune system to attack tumors. And so we've seen, like in melanoma, we've seen drastic, huge success with some of these newer drugs in just the past few years. So my hope is that because we've seen that kind of success with other tumors that were very aggressive and not very treatable in the past, maybe we'll begin to see more of that success with sarcoma in the future. So I hope that people watching this video in 5 years will say, wow, I'm glad that we've made such progress in such a short time with sarcoma. I really hope that's the case. It's promising, but we still need more work.
Okay. I believe I read that DFSP is due to translocation of chromosome 17 and 22. When I asked my oncologist about this and asked if they knew or if any research had explored what the catalyst for this translocation was, he stared at me blankly. Maybe my question was sophomoric. At any rate, is it known?
That's the question was, why does the translocation happen? Why do the genes break apart and fuse together and make this special 1722 translocation that drives DFSP? I don't think we know why translocations happen. There are people that have, I think, begun to look into this, but we still don't have a really good answer. As far as I understand, it's relatively random event. We don't really understand or can predict why it happens. And it's not just DFSP. There are many other types of sarcomas that have translocations. They're different genes that are involved, but that same pattern of two genes breaking apart, hooking back up inappropriately with each other, and then a tumor develops. Ewing sarcoma, synovial sarcoma. There are many, many different sarcomas and also lymphomas and other types of tumors. And we're discovering more of these translocations all the time, but we don't actually know, really, as far as I'm aware of, we don't really know why this happens. So unfortunately, it's not a sophomoric question. It's a really good question. We just don't have a really good answer to it yet.
This is something we talked about earlier as well. Mine might be the most ignorant question of all. No, it's not. I keep feeling if I'd not gone to the derm the day I did by chance, and he decided not to do a biopsy on something that was there for at least 14 years and looked no different, would it have grown slowly enough that I would have led a normal life without surgery? Would it have just stayed contained and I might have lived a life never having been bothered with it at all? Or by it?
That's a really, really great question. And it's a question I think about a lot, actually.
Yeah, we were discussing earlier whether...
We see patients with DFSP for 10, 15, 20, maybe even more years that has not bothered them. It's just been there as a lump and bump that kind of comes and goes or gets bigger slowly. And then only by chance they get a biopsy and find out it's this rare sarcoma, get a big surgery, have scarring, have all these side effects. Maybe if they just would have left it alone, would have never known, would they have gone on the rest of their life and never had a problem from it because the tumor grew so slowly? And I don't know the answer to that question. I think that most people don't end up having a bad side effect like a distant metastasis from the tumor. But I think because some people do, it's probably better that we try to remove it in hopes to avoid that outcome of spread of the tumor. But it's really a question that I've pondered a lot, is that so many people have had it for so long without a problem that, you know, maybe are we being overly aggressive with that? I think that most people in medicine, including myself, feel like we probably should continue to aggressively treat it to make sure that we remove the tumor. But there are times in medicine where we have a tendency to want to always treat, and sometimes we have to stop and ask ourselves, is this the best thing? And one example of that is desmoid fibromatosis. In the past, we aggressively treated it. Sometimes we still do. But there's a growing trend that some people are starting to think maybe we should leave it alone. Maybe we should treat it with non-surgical techniques. Not everyone agrees with that, but there's an evolution in the way we thought about that tumor. The one big difference is desmoid fibromatosis never, by definition, never spreads to other parts of the body. So technically it's not a cancer, but we do treat it and think of it as a cancer because it can be locally aggressive. So DFSP, though, I wonder if over time, as we begin to get a better idea and better understanding of this disease, as I hope we will with the research we'll do with this group, because there are so many patients here, maybe we'll get a better answer to that question over time. Maybe there will be other alternative methods that we can do that are less aggressive than drastic surgical treatment, but I don't think we're there yet. So I think it's certainly a compelling, interesting idea, and it's certainly something that we should look into and have an open mind about. But I think as of right now, for most patients, having the tumor removed is probably the safest bet. There may be rare exceptions to that, but I think that probably overall most doctors would agree that right now, with the information that we currently have, that's probably the best approach. But it's definitely something I think about a lot, and I wonder if we'll have a different understanding of this in the future.
Would you like to ask the next question?
We talked about this earlier as well. My surgeon could see a deep-seated scar close to my skull, which appeared to be the root of the tumour. This scar was on the site of a biopsy I had when I was just 4 years old, so 40 plus years ago. I know there's been references to DFSP being linked to injury sites, but I don't understand how this can be when other research refers to the translocation of chromosomes. Confused. What is the current thinking?
You guys bring the hardest questions. It's good. This is good. So the story is that the patient, as a young child, had a biopsy, and it was almost 40 years ago, and so there's no record of what the biopsy showed, but presumably it was probably something benign since nothing else was done at that time. And then 40 years later, there was a nodule that developed at that site, thought to be a cyst, and then once it was biopsied and removed at that time as an adult, it turned out to be DFSP. So the question is, and the surgeon said that when they removed it, they saw some scar tissue down in the center of the tumor. So did the biopsy that was done 40 years ago cause the DFSP, or was the DFSP there all along and just not doing anything? I think it's an impossible question to know, and I would really love to see that biopsy from 40 years ago. I would really love to have answers to that. But unfortunately, since that information is lost, we can only do guesswork. I think that, again, we talked about, is it possible that injury or trauma could cause a DFSP to grow? Potentially. Could it cause a DFSP to form? I suppose theoretically it could be associated, but I think more likely when we see trauma and then sarcomas, most of the time I think it's probably a coincidence. There are some cases I've seen that were really massive trauma that other types of sarcomas grew out of massive, like someone who had a bad gunshot wound or a motorcycle accident where they totally fractured the multiple bones and then a sarcoma grew later. So in those cases I kind of think the trauma may have had something to do with it. But I think most of the time when there's minor trauma, probably coincidence. So I would imagine in this case that maybe the DFSP had actually been there that whole time. And on a small biopsy in a young child, especially 40 years ago when people didn't know as much as they do now, if we think that the knowledge is limited about DFSP now, imagine 40 years ago, much more limited. We didn't know about the molecular translocation at that point. So it's very possible that it could have been DFSP that whole time. Maybe the biopsy didn't show it wasn't deep enough. On a small biopsy, it's very hard to diagnose DFSP. I struggle with it personally, and I spend a lot of time thinking about this and looking at this. So I don't know the answer. I think it's a good question, though.
Last question. Are providers who diagnose DFSP required, or at least should they be required, to report the data of the diagnosis to someone, i.e. NIH or CDC? I mean, I know HIPAA is big here, but we could potentially be missing out on vital research data.
So the question is, when a new DFSP is diagnosed, is that required to be reported? So different countries have different rules, I think, about what diseases need to be reported. Some diseases are mandatory to be reported to different government agencies for tracking purposes, particularly some infectious diseases. With cancer, usually larger cancer centers do report, in some form, report their data, in the United States at least, back to governmental agencies. So there's a database called SEER, S-E-E-R, and it tracks the incidence of cancer and information about cancer. And there are different good and bad things about the SEER database. In general, it's a good thing, but it doesn't always have totally complete data. And there's different ways that data is reported back. So should it be required? I don't know. That's a good question. And there's complicated things to that because it's a complicated question. It's complicated to know about what diseases need to be tracked. And there are ways to anonymously report that data without violating patient privacy, that you can give information about a new tumor that's been diagnosed without saying who it was who had the tumor. But the things about it are, it needs to make sure that it's in a certain format, that the diagnosis is totally correct. Because otherwise what happens is if you get incorrect diagnoses in there, it can really mess up the database. And then the data that's there is not as reliable as it could be. And I think sometimes with databases we see that problem happen, that we get a lot of different terminology used, and then it makes it difficult to understand what the data really means. So if we want to collect data, we want to collect it in a way that's going to be meaningful, that other doctors can look at it and actually make sense out of it. So we're trying, there's attempts to do that, but I think that we probably could do more in that area, but I'm not sure exactly how. It would be a big thing that needs to be done, certainly more than I can do. But yeah, it's something we probably should look into doing more.